the fuck? Oh. Hello, Daniel. Can you hear me okay? Hi, Daniel. Can you hear me okay? Hi, Daniel. Do you know where the mute button is? The mute.
Yes.
Hey, there you go. How you doing?
I'm doing well.
Very good. Where are you from, Daniel? I think I met you before, right?
I'm from DR Congo.
Oh,
Democratic
excellent. Welcome.
Republic of Congo.
Welcome.
Okay.
Okay.
Thank you.
This will not be interactive. Maybe we can ask some questions if you want. Okay.
Okay.
How's Dr. Kabulo doing?
I didn't catch you well.
Do you know Dr. Kabulo?
Okay.
Dr. Kabulo, yes, we are just interacting with him on WhatsApp.
Oh, good.
Long holidays
Good.
of Ramadan
Okay.
and so
Okay.
on.
Welcome.
We're happy to restart our scientific meetings, and we are transmitting live from here from Amman, from Farah Medical Campus in Amman, Jordan. And the backdrop is these views of Wadi Rum, which is near to Petra, and it is one of the world wonders. Recently, this film, Aladdin, was filmed and pictured in Wadi Rum. So I want to show our international audience the beauty of Wadi Rum. That's okay. Just stop it. We're not getting the voice, however, you can watch the backdrop of some of the beautiful views of Wadi Rum, where so many pictures in Hollywood were filmed here. Most important of which is the Lawrence of Arabia by Omar Sharif and Peter O'Toole in the 60s. So Will Smith was so happy in Jordan, and I hope all the viewers internationally can come and visit Jordan. Okay. All right, we'll go to the presentation. It's hypothalamic-Pitutary Langerhans cell histiocytosis. It's a long title. Let's explain it. Langerhans cell histiocytosis. Enigmatic disease with so many unanswered questions. We don't know whether it is a neoplasm or it's an immune disorganization or dysregulation. The view now, the current view, although not final, that this disease is probably a neoplasm. So Langerhans cell histiocytosis, that's what we'll start with, and we'll end here. But in between, so many names have been used in literature: eosinophilic granuloma, Hanschel-Christine disease, literal Sui disease, histiocytosis X. Let me take you through history and go back to this man, Paul Langerhans. He was a Berlin, Germany medical student. He was age 17 or 18 when he made major discoveries. He died early, actually, at the age of 41 by tuberculosis, and he got married to a widow of one of the patients with tuberculosis. He visited Jordan, he visited Palestine during a trouble. So what did he discover? We all know about the islets of Langerhans, which is islands of Langerhans or islets of Langerhans in the pancreas, which is his major discovery. And he also discovered a cell in the epidermis. He was 18 years of age, medical student, when he discovered in the skin this dendritic kind of cell, and he called it by his name, Langerhans cell. And this is how this cell appeared in the new microscopic views. Then came three people, Alfred Hand, Arthur Schuller, and Henry Christian from Philadelphia, Vienna, Boston. They described different patients with what they called eosinophilic granuloma, usually bony lesion associated with diabetes insipidus and so on. So they all described this in spite of living in different periods. So Alfred Hand, I don't have a picture of him, from Philadelphia. Arthur Schuller, for many, would be surprised that he's the father of neuroradiology. He was the first one to put a book about the skull base back 1905. And Henry Christian, again, described the same thing. So three people described similar lesions. That's why people decided to call it Hand Schuller Christian disease, taking the names of the three pioneers. And then two other people came, Erich Literer from Germany and Stuart Saiyd from Stockholm. They described a very advanced case of fatal disease, of systemic disease. And they call it Literer-Saiyd disease. But we are describing the same disease, but in a very advanced form. Then came this man, Lichtenstein, in New York, and he said, what's the problem? Sometimes we call it eosinophilic granuloma, sometimes we call it Hand-Schuller-Christian disease, let's call it Histiocytosis X. And with the X, he's referring that we don't know the diagnosis, we don't know the cause of it. So X is the unknown etiology. So this terminology, Histiocytosis X, persisted in literature. Then came this man from France, Nizelov, and he said, come on, we'll not call it Histiocytosis X. We know this is Langerhans, this is histocyte. So let's call it Langerhans cell histiocytosis. That was back in 1973. And then 1987, there was a society that started working called Histiocyte Society. Said again, we confirm that Langerhans is histocytosis, i.e. Langerhans cell is histocyte, and we classify this Langerhans cell as class 1 histocytosis. So histocytosis, a disease which involves the histocytes, was classified into class 1, class 2, class 3. Class 1 is the one describing Langerhans. Class 2 is describing non-Langerhans histocytes, but other than Langerhans. And class 3 is the malignant form of histocytes or histocytosis. So here you are, the final classification by the Histocyte Society. Imagine that there is a society of just describing the histocytes. Class 1 is Langerhans, class 2 is non-Langerhans, class 3 is the malignant one. And then a new, more recent revision that the class 1 Langerhans is also called dendritic cell because it is dendritic with so many branches coming out. Class 2 is the non-Langerhans, also called macrophage-related histocytosis. And they define the class 2 into 2A, related to the skin, dermal one, class 2B, which is not related to the skin. The most famous is Rosai-Dorfman's disease. And class 3, which remains as it is, malignant histocytosis. So basically, Langerhans cell histocytes or histocytosis is a form of histocytosis. So Langerhans cell by itself is a cell which is present in many places, like in the skin, in the external genitalia, in the respiratory epithelium, but its origin is from both the myeloid and lymphoid precursors. So it is the first defense line for your body. It is the macrophage that will attack any insulting agents, and by making contact with them, it will present some antigens, and these will react with the T lymphocytes, and then a reaction occurs. So Langerhans cell histiocytosis is a clonal proliferation of a bone marrow-derived dendritic cells, the so-called Langerhans, and with it there are T lymphocytes, eosinophils, multinucleated germ cells, and normal histocytes. So let's think of Langerhans cell histiocytosis as a neoplasm. Incidence, more in children than in adults, 8 to 10 cases per million per year. So in a country like Jordan, say we have now 10 million, we're speaking about 100 cases per year if all the cases are treated here in Jordan. Adults are less, so basically Langerhans cell histiocytosis affects children more than adults. The age peak in children is 1 to 3, in adults 30, 40, and unfortunate for us males, we are more than females. It could be localized, it could be systemic. When we say localized, we mean single system, but it could be multiple lesions. So on the skull, it is a bone, we have single lesion or multiple lesion, but we are in the same organ, so it is called localized. The multiple are affecting multiple organs, and this is usually life-threatening. In children, it's more of a cranial. In adults, it's mostly extracranial. Indications for poor prognosis with mortality of up to 20%. Young children, if multiple organs are affected, if you give a treatment and they don't respond initially, if you start having systemic failure, and if the ears are involved. This is for our ENT colleagues. ENT or ear involvement is a bad prognostic sign. And of course, in us and in neurosurgeons, neurology, the presence of diabetes insipidus. These are bad prognostic signs. What are the organs affected? In order of frequency, skin, bones, CNS, but then every other organ in the body, hepatobiliary, lungs, lymph nodes, soft tissue, bone marrow, salivary glands, GI tract. Skin can be in a form of rash or petechiae or ulcers. Look at these forms here. So we always see kids like this. So it's very frightening that this could be a fatal disease if we don't treat it. Look at this. And the groin, and the tummy, the face, and the hands, and the legs. And look at this paper describing congenital Langerhans. It's called it blueberry muffin baby. It's really looked like a blueberry muffin. The lesions of the bones could be lytic, could be osteoblastic, or even osteoporotic, or just hypercalcemia. And they affect any bone in the body, but they love facial bones, they love the skull, vault and base. This is one of my cases. And I have really a good number of cases of Langerhans. I'm just being lucky. You can see the bony destruction here, there, and you can see that we have done the surgery for the patient and treated him only with indomethacin in addition to the surgical resection, and this is the histology. So this is histologically confirmed. Another girl, by the way, I have no idea why. This patient was an Iraqi boy. This was an Iraqi girl. And the other cases I'm going to describe were all from Iraq. I have no idea why. Maybe because of the use of the forbidden weapons on the people of Iraq. So this is the lesion affecting the orbit. I've done this with Dr. Mahmoud Al-Assad. We cooperated in doing excision, but look at this. She was presenting with this mass. And when we treated her, she went back to normal. So this is the lesion before, and this is after, with the reconstruction of the orbit. Another paper presenting Langerhans cell histiocytosis of the orbit. Look at this here, or here, and there. Langerhans cell histocytosis of the temporal bone, like this. That's why I said the ear involvement or the ENT involvement is very important. And this is completely destroyed the temporal bone. So pathological manifestations are important. Why? Because mostly they occur in children. And how frequent do we see otitis media and external otitis in children? Very frequent. So if you don't think about the disease, you will miss it. And these people will go into fatal disease. Unusual location of histiocytosis X, presented in 1991 in the clinical neuropathology, where in the petrous apex, one of the unusual sites for this disease. Again, ENT, the Radiology Otology Journal, 2010. See the amount of destruction here. And what was the presentation? CSF otorrhea. Another case in the literature about the clivus being involved. Solitary Langerhans of the clivus. Can affect the bones, vertebrae, destroying them. Vertebral Langerhans disease, and 88 occurs in children, usually in the thoracic spine. Now, what about CNS involvement, which is the third in line, after the skin and the bones? They love Langerhans cell histocytosis, love the hypothalamic-Pitutary axis. But not only that, they can actually go into the brain. But this is the commonest hypothalamic-Pitutary axis. So you can see hypothalamic-Pitutary axis involvement up to 50% in children, now up to 25% in others. So it's very common. Look at this before contrast, look at this after contrast. The stroke is only contrasting. And I get so many referrals for patients saying that this is pituitary and they need surgery. The answer is no. Because the stroke is involved and it is taking contrast, you have to think of Langerhans cell histocytosis. Somebody mentioned to me, why are you presenting this rare disease? Because of this, so that you'll not fall into mistake of not treating or over-treating or under-treating these cases. By the way, pituitary lesions constitute 20% of our practice as neurosurgeons and neurologists. This is one of my cases, 23-year-old male, which is unusual in adults. But look at this, involving the pituitary, involving the hypothalamus, involving the stroke, and so on. When they affect pituitary, they can affect the posterior pituitary or the anterior pituitary, which is the commonest, posterior pituitary, more than anterior. If you affect the posterior pituitary, the commonest presentation is diabetes insipidus. So it is called central diabetes insipidus, and there are so many differential diagnoses for that. If you affect the anterior pituitary, especially in a child, you'll get deficiency. If you get a growth hormone deficiency, you'll get a child who's a dwarf. And if his family doesn't pay attention to the stature, this boy, after 9 or 10 years of age, will go to stay as a dwarf, simply because we did not think of Langerhans cell histocytosis. We have to stop thinking of diseases as 2 or 3 in every area. Pituitary adenoma, craniopharyngioma, and so on. Abdominal pain in a female is ovarian rupture cysts or appendix. It's much, much more than this. And if you affect the hypothalamus, then you will get the hypothalamic manifestations. Hyperphagia, hypo or hyperthermia, obesity or underweight, memory changes because of the connection of the hypothalamus with the memory system, change of appetite, change of sleep pattern, temperature changes, behavioral changes. This paper by Robert Spitzler and group in Texas, 2006, speaking about isolated Langerhans cell of infundibulum presenting with fulminant diabetes, isolated, no other place in the body affected, just this, the stroke and the hypothalamus. And in New Zealand journal also, a case of involvement of the pituitary and the stroke. And this paper in Spanish, alterations, endocrinus, in I don't know how to read it, but you can see the involvement of the stalk and the pituitary and so on. You may easily miss this as pituitary adenoma. And if the prolactin is slightly elevated, which is usually the case, it is called prolactinoma, and it's treated with drugs or by surgery. And this is a fatal mistake, simply because the treating physician is not aware of the many diseases that's affecting the pituitary. In Endocrine Journal 2016, and this interests our endocrinologist, pituitary gland in patients with Langerhans, a clinical radiological evaluation. Look at this. Another paper from the Hellenic Endocrine Society 2018. Look at this. All of us will diagnose this as possibly pituitary adenoma. Or this paper of isolated in female adults, which is rare. Look at the involvement of the pituitary. In addition to involving of the pituitary hypothalamic axis, you can get a cranial involvement. Here, in the cerebellum and in the brainstem, in the corpus callosum. It's called the neurodegenerative disease. And this would look like so many diseases in the neurology, like Jacobs-Fitzgerald, alcohol encephalopathies, and so on. It can affect the basal ganglia. It can affect the brainstem. Can affect the pineal. So not only the pituitary hypothalamic axis. In this paper, it's affecting the temporal and the brainstem. And this paper is affecting the pituitary and the pineal. It can, of course, cause bone marrow infiltration, and this is very important for staging. And if you do TC bone scan, you will see involvement of the bones in different parts of the body. It can affect the soft tissues in the neck, in the parotid, in the thyroid, in the parathyroid. And this is a connection between Hashimoto disease of the thyroid and the lymphocytic hypophysitis and the Langerhans cell histiocytosis. Can affect the thymus. Can affect the chest. Look at this. Infiltration, cysts. Can affect the liver. Look at this. Can affect the cholangitis, cause cholangitis and biliary system. And in this paper, liver involvement in children, 2015, liver is involved and it's presenting with gastrointestinal bleeding. How often we think of Langerhans cell histiocytosis and patient coming to us with bleeding? We think of two things, ulcer or maybe Crohn's disease. Stomach is involved here, small bowel is involved here with some ascites. What is the treatment of these cases? So long we think of them as tumors. We have medical treatment, we have radiation treatment, we have surgery. Always we start with medical if we can, by giving steroids. I don't know, Dr. Mohammed Sarhan is here. He did not arrive. We treated many cases with just indomethacin. And biphosphonates, interferon, and of course you can go to chemotherapy. Or you give radiation, or you do surgery if you are in doubt by taking biopsy or by excision. Chemotherapy, many chemotherapeutic agents are there. They can be used and reported. Vinblastine, azathioprine, methotrexate, etc. And this is a paper in France, 2011, about the use of vinblastine for treatment of Langerhans cell histiocytosis. You may ask me, how did they know that this is Langerhans cell histiocytosis? If there is extracranial involvement and we diagnose Langerhans, most likely this is what it is. If there is not, then you'll go for biopsy. But after you diagnose, you can give the vinblastine, and this is the response. This is the lesion, and this is almost cured after 6 months. Lesion disappearing after 1.8 months, after 8 months. Chemotherapeutic agents after 12 months. And recently, they have been using ICDA, which is anti-metabolite, the 1-chlorodeoxyadenosine in the treatment of these cases. They reported 12 patients, mostly children. They have multi-system involvement and total response in 8, partial response in 4, which is very good response. Look at this response. So we'll come to our case presentation after this initial talk about the Langerhans. This is an Iraqi, again an Iraqi. Why? I have no idea. But I would say 90% of my patients were Iraqis residing in Iraq. 39, very unusual age for a male presenting with this. He's from Kurdistan. He presented with recent history of headaches, blurring of vision. But on questioning him, he had for 1 year impotence, polydipsia, polyuria, and general fatigability. In his past history, he's hypertensive on treatment, and he said that he had surgery for multiple bone cysts, which we could not elaborate, no reports, nothing. Dr. Sakhar, are you here?
Yes.
Could you please report on the... You may ask why I asked Dr. Sakhar, because he was the one in charge of this case back in 2005 at the Arab Center.
Very old history. Good evening. This is the sagittal image MRI. This one? Okay. It is obvious that it is without contrast study. What we see is a large, lobulated, solid, soft tissue mass lesion, primarily epicentered on the suprasellar region. This is a very good point to notice. When you deal with suprasellar or cellular pathology, look for the center of the pathology. If it is centered on the cell itself, it is mostly likely to be intracellular tumor. Second point, the tumor is involving multiple organs. As we said, the optic chiasm is lost in definition. The infundibulum is lost in definition. It is obscuring and عامل نوع من shadowing over the posterior pituitary region. We can notice that the bright spot of posterior pituitary is lost in this case, which take us to a narrow area of diagnosis. We can notice that it is expanding posteriorly into the interpeduncular cistern and upper part of the prepontine cistern. Superiorly, it is approaching the area of the floor of the third ventricle, hypothalamus, and supraoptic chiasm. Coronal images would be better for this diagnosis. The entity is purely solid and mainly suprasellar. This is what you can see in this image. The second image is enhancing sagittal image for the pituitary region focus. We can notice that the cella itself is clear. It is not primarily a cella originating or pituitary originating tumor, though it is in relation directly with the posterior surface of the pituitary. It is involving the posterior part of the pituitary gland. The same is noticed, it is a diffuse enhancing lesion. No visualized cystic or cavitary areas. It is negative again for calcification, cavitation, flow void, fat components, and other things. Can you see other image? The same, compare the post-contrast images. Still, we have seen the normal pituitary tissue and the enhancing large nodular soft tissue lesion occupying mostly the suprasellar and partly expanding into the hypothalamic region, obscuring the infundibulum and optic chiasm. This is a coronal suboptimal image, really, but you can notice the normal pituitary tissue. This is the cavernous sinuses. The mass is expanding in the suprasellar area. There is a real cleavage between the solid mass and the pituitary tissue itself. Superiorly, this is the floor of the third ventricle and the supraoptic cistern. It is infiltrating this area, which is partially or part of the hypothalamic region. Hypothalamic region is an area between the thalamus and the pituitary gland, and the infundibulum is the communication between the two. So this is digital image, coronal image for the same patient, intensely enhancing without evidence of necrosis or cavitation or other things. It is not infiltrating the cavernous sinuses. It is limited by the space. The pituitary itself, fossa, is not expanding, which again indicates that it's not an intracellular tumor, it is a supracellular tumor. Same information we got from these multiple series images. It is partially deforming the base of the third ventricle. It might be causing hydrocephalus, since I can see that there is dilatation of the lateral ventricle. So we are dealing with supracellular solid mass. It could be arising from the supracellular structures, which to me could be arising from the optic chiasm, from the infundibulum, from the hypothalamic structure, and involving the posterior pituitary, where we see the loss of the spot, bright spot line. The spot indicates the posterior pituitary involvement and the posterior part of the pituitary gland.
Thank you, sir. Thank you very much. Any comment from our radiologists? Dr. Azman Hadidi, any comment?
So according to this picture, what's the differential for the radiologist?
We will
Does
come.
the radiologist think of Langerhans or Histiocytosis?
We will come to it, Ahmed. Ahmed Ahlala, any comment? Dr. Azam? No. Okay, we'll proceed. Any other radiologist I can't see from here? Okay. So we did the usual investigations. We noticed that he's a little bit anemic, but repeatedly the hemoglobin started to rise with transfusion. PT and RPTT were normal, urea, creatinine, sodium, potassium, magnesium were normal. And we did a few consultations. I cannot remember the ophthalmologist who did this consultation, but he diagnosed that the patient has bitemporal hemanopia. Ibrahim, would you diagnose this based on this or what? Dr. Ibrahim Sadat, ophthalmologist. I could not find the name of the ophthalmologist.
Actually, the patient has diplopia, I don't know why, but confused vision. Visual acuity is good in both eyes. And this is visual field. This is an old type visual field. We don't use it usually anymore. It's called Goldman visual field. Nothing.
2005. So.
Yeah, bitemporal hemanopia.
Thank you. Dr. Arnaud and the chronologist. I always put what everybody writes so that they cannot change their minds.
So actually, we diagnosed it, total diagnosis. So we presented with this case, and you can see it's a multi-organ disease, and mainly, as you can read here, that he had a severe headache, and there's a supracellular mass. So what was the differential for me is that it might be a brain tumor, granulomatous disease, or some kind of pituitary stalk adenomas. The workup showed that he's having low T4 with a normal TSH.
That's the complaint.
Yeah. Normal cortisol, low ACTH. So that means there's a destructive lesion affecting the pituitary secretions. T4 low, the TSH relatively low. The cortisol level was normal, but low ACTH, LH, FSH were low. And you know that whenever you have suppression of the negative, the prolactin will go up. So it indicates that the stalk is affecting the pituitary secretion. Okay, so what we plan was to have a biopsy. Okay?
That's the complaint.
So the complaint was that general fatigue, impotence, polydipsia, polyuria. And as you have shown that we have low T4, low STH, gonadotropins were low, and the prolactin is high. ACTH is low, testosterone is low. So it's a central mass affecting the pituitary function.
Okay. Dr. Amar. Dr. Amar is the son of Dr. Yasser Amar, a famous orthopedic surgeon. هذا الشبل من ذاك الأسد.
يعطيكم العافية أول شيء الله يحفظكم. I'm a surgeon, so I was called to do. We don't think a lot; we just act. They had this 39-year-old gentleman with multiple bony lesions in the radius and ulna in the forearm. As you can see, there are little periosteal reaction or really no periosteal reaction. Of course, multiple as well. With the combination of the increased parathyroid, decrease in vitamin D, calcium, phosphorus, a biopsy was indicated. This is the operative note for me. And it was cystic. The material was fluidy. And we did the biopsy from the distal ulna, which was the most accessible one. That's it.
Okay, thank you very much. We also consulted with Dr. Ubaida Masud. Is he around? I asked him to come anyway. He looked at the patient and he diagnosed crackles, listened to crackles in his chest, and saturation was 85 to 90%. And this is the chest X-ray. You can see the infiltration there. And this is his CT chest. So really, the good involvement of his chest. So this is for you, Dr. Mahmoud Khatib. You asked about the differential diagnosis. As I said, we have to stop limiting our thinking of 2 or 3 diseases. Otherwise, we'll be prisoners of that diagnosis. And to be a prisoner of your diagnosis is a recipe for fatal mistakes. Anything in the pituitary, you have to think of pituitary adenoma, obviously. They could be small, they could be large, but always pituitary adenomas come first in line. And if you look at this here, you may think of this as pituitary. Sorry. In relation to the pituitary, there are diseases that we do not think of. We don't think that there is something called hypophysitis, whether it is lymphocytic or granulocytic or otherwise. There are 3 types of lymphocytes of hypophysitis. We don't think about them. And look at this, they exactly look like our case, like Langerhans. So don't tell me the rare diseases should not be discussed. They must be discussed. And we must elaborate on them, and we must expand our knowledge. Supracellular colloid cysts. Colloid cysts are in the 3rd ventricle. Do we have colloid cysts in the cell? Yes. And this is one of my cases, histologically proven. Epidermoid. Would you think of this as epidermoid? And this is again one of my patients. I operated upon him, or her, I can't remember. Male, 45.
Dr. Ibrahim, the clue is the rim, right?
Yes. Well, it could be anything. It could be Rathke's pouch. It could be abscess. It could be so many things. And again, this is one of my cases, hypothalamic-Pitutary. And this is one of my patients. He was 1 year old, and he came with precocious property, genitalia of an adult, 1 year old, due to the hypothalamic-Pitutary, which usually causes gelastic seizures, infrequent and controlled laughs, and so on. So we did the surgery for him. Of course, craniopharyngioma should be thought of in that area. I'm choosing my cases of a craniopharyngioma that looks like our Langerhans cell histiocytosis, very much like the same picture. Rathke, meningioma, germinoma. These are cases of mine, so I'm not giving you pictures of books. These are actual cases that I operate upon, histologically proven. Plasmacytoma affecting the clivus, why not? Teratoma, immature, metastasis of the pituitary. They love to go to the posterior pituitary because it is rich in blood supply. Why do they choose that? We don't know, but they are there. These are diseases that are there. We have to think about them. We cannot ignore them and just limit our thoughts into just a couple of diagnoses. Optic glioma, I think this is the largest optic glioma in the literature, one of my patients. Astrocytoma of the hypothalamus, sarcoidosis. Imagine if somebody would give gamma knife for this. Just because he is a bad neurosurgeon who cannot operate, who cannot take a biopsy, and they would give gamma. And they call it gamma knife, which is a misnomer. They treat people by using gamma knife. It is called stereotactic radiotherapy. Chordoma, choroid plexus papilloma of the third ventricle, one of my cases. Aneurysm, one of my cases. Oligodendroglioma, arachnoid cyst, esthesioneuroblastoma, olfactory glioma code. And this is a very unusual presentation. Primary lymphoma of the pituitary stalk in immunocompetent 9-year-old child. Not immunocompromised, he's immunocompetent. And it is the only single lesion.
How many cases reported?
And this, I am myself and Ala, in the last couple of years, we had 11 cases of Cns lymphoma. And again, 7 of them are Iraqis. So, radiology of that area, because we are neurosurgeons. What happens if you have Langerhans and Histiocytosis in that area? Something happens to the infundibulum, something happens to the pituitary, something happens to the hypothalamus. Fundibulum will get either enlarged, thickened in 50%, but in 15% you get atrophy, and you get empty cellular syndrome. Pituitary is the same, as Dr. Sahar alluded to. The first sign is the loss of T1, the bright spot of the posterior pituitary. Do T1, look at the posterior pituitary, it's always bright. If you lose that, think of pathology there. Not necessarily Langerhans, but diseases that we mentioned. You may get pituitary mass, you may get pituitary atrophy with empty cellular syndrome. And the hypothalamus, you'll get a mass there, as we have seen. So, loss of bright spot of the posterior pituitary, infundibular thickening, hypothalamic mass, or empty cellular. These are the radiological picture of this disease. How do we diagnose that this infundibulum is thickened or atrophied? The usual thickness is 3 millimeter. That's in the coronal view, but mainly of other views. But the coronal is the best. 3 millimeter, less than 3 is normal. 3 to 5 is enlarged slightly. More than 5 is definitely enlarged. So we have a criteria that we go by. Paper, pituitary stalk thickening in the case of Langerhans histiocytosis. Look at the different images of this disease. Here, here, and there. So we did surgery for this patient simply because he was losing vision. Second, we did not reach to a different diagnosis. Although we have the bone lesions, we actually started with the bone lesions. We asked Dr. Amr to take a biopsy of the bone, but because it's bone and needs a decalcification, it took about 10 days to get the result. Meanwhile, we went for surgery. And I'm going to show you still pictures because the quality of the video was not optimal. But this is pterional approach from the right side. This is right optic nerve. This is left optic nerve. This is chiasm, carotid artery, and this is the mass appearing there. That's the mass. So optic nerve, chiasm, that's the mass. Here is the stalk going into the pituitary. It is enlarged. So we start excising it from the inter-optic space. And then we come to the optic carotid triangle or axis. There it is, carotid, optic nerve, tract. So we separate carotid from the optic. We start seeing the mass. Here is the mass. So here we are in this space, and we start excising it. Of course, we're not aiming at total radical excision, we're aiming at a good excision that would give the patient relief of his vision at the same time give us a good diagnosis. So that's the end of it. We have removed it from here, we have removed it from here. So this is pre-op, this is the tumor here and there, and this is post-op. Histology, Dr. Farsad. Of course, we'll start with the brain pathology because that's what we got first. The bone pathology came later.
This case is interesting. The brain bone pathology came before the brain. The pathology of the brain results came before the bone, because bone usually needs decalcification, it takes some time. You can see typically this is a histology that makes you suspect that this Langerhans histiocytosis. There are many cells, histocytoid we call them, and some eosinophiles, and there's some giant cells. And this is usually the mixed pattern of cells that you see. And there are some many intermingent lymphocytes, and you can see plasma cells. So it's basically a mix of cells, but to show you what really triggers the diagnosis, the histology of that Langerhans is usually somehow striking. You can see these usually are the Langerhans cells. Usually they have coffee bean appearance. I'll show you more cells in here, and you can see that the cell كأنها حبة فول النيوكليوس تاعتها. This should alarm the pathologist that probably you are dealing with a Langerhans, especially if you see many of them here. بنسميهم مرات kidney shape or bean shape cells. These are histocytes. They are mixed with histocytes, normal histocytes, and mixed with giant cells and with eosinophiles. You can see some of them cells are really, they have this coffee bean. Show you more better pictures. Probably sometimes with a microscope, because we change the focus, you can see them better than in the slide, static slide. This is not this is blood vessel. You can see this is good picture. You can see coffee bean shape, typical eosinophiles. You can see them again. And pathologist, any good pathologist, once he sees something like this with eosinophiles, really should trigger for him very strongly. This is histiocytosis, eosinophilic granuloma, or Langerhans histiocytosis, and you need always to confirm it by immune. لأنه هلا بطل حدا يقتنع بالهistology alone. You always need to confirm the diagnosis beyond doubt. لأنه the treatment صار بيختلف كثير. Again, you can see how the cells are being shaped. Eosinophiles usually they are scattered. Sometimes for the form an abscess, and you can see this is many of the Langerhans cells. We'll see we have special stains now for Langerhans cells. We'll elaborate on more of them. This is one of the earliest stains that stains Langerhans cells, which is S100. S100 stains 100 other things, but we S100 stains 100 other things. That's why probably it's called S100. But within the good setting, you can see how it stains the bean-shaped nuclei, other cells, lymphocytes. Once you see this, this is very good. Now we have 3 good stains for Langerhans. This is another stain, CD1A. Actually, this was negative for CD1A, but this does not exclude it, because we have 90% of the cases are positive, 10% are negative. That depends on the antigenicity of the tumor cells. This is CD68, and this also, because they are histocytes, CD68 is a histocytic marker. They stain Langerhans cells, but this is not specific stain. The third stain, which is S100 CD1A, the third stain is called Langerhans immune staining. We don't have it in Jordan. We don't need to have it, because I think with the morphology and 2 other stains, we feel confident. This is chromogranin. Chromogranin is staining because this was in the pituitary to see if this really could be any sort of abnormal pituitary tumors or microadenoma. it was completely negative. Epithelial membrane antigen also for other tumors, we have to exclude it not to be lymphoma, sort of lymphomas that are AMA positive or meningiomas. It's completely negative. So we call this is Langerhans histiocytosis X. Then we worked on the bone. البون specimen يعني زي ما تشوف السبيسمنت received 7-5 لكن الدياجنوز طلع 20-5 لانه البون ديكال sometimes it's really when heavy sometimes takes us for more than a week to finish the bone لانه بيسوي له decalcification في البون. هذا البون is very difficult to cut by paraffin blocks, so you have to remove all the calcium from it, but this is called decalcification process. But you can see this is the bone and this is trabecular bone, but there's areas which are tumor مختلفة شوي عن other bones. Again, you can see typical giant cells, eosinophils, many eosinophils in this case, and histiocytes, plasma cells. Again, you can see the same pattern of histiocytosis, again, or more of the same pattern. Giant cells. Again, typical when you see it in histology, you suspect it highly. Then you do S100, you can see many positive. Brown staining is the positivity, many positive cells. But these are the ones that are staining and looks morphology like Langerhans cells and stain with S100. These are actually Langerhans cells. And so we call this Langerhans histiocytosis. The CD68 was positive as in the original, CD1A was negative as in the original. And so we called it histiocytosis X. As a pathologist, I usually diagnose histiocytosis X once every 2 or 3 months. I have seen cases in the pituitary, in the bone, but I have seen cases in the lung. Unfortunately, مرة أنا شخصت حالي in the lung يمكن قبل 2 years ago. The pulmonary, he was so surprised. He called it, this is the first time that I ever see histiocytosis X. By the way, histiocytosis X in lung usually occur in smokers. طبعا patient كان smoker. لكن قلت له النقطة إنه قال لي it is very rare and not diagnosed. قلت له it is not rare and it's not undiagnosed. The problem, our pathologists, they don't diagnose it. So you don't get to it. If you don't have a diagnosis, as a pulmonary, you will not go to diagnose histiocytosis X. طبعا الحالة لأنه اختلفت فيها مع multiple labs, we sent it to United States to one of the most prominent professors, اسمه Professor J. Roby MD Anderson, and he confirmed that diagnosis. This typical case of Langerhans histiocytosis. But the point that if your pathologist does not diagnose it, you will not see it. But you have to rely on a very good pathologist to diagnose these difficult cases. Thank you.
This is post-op, and you can see that always when you come from the right, you will remove the tumor on the left because the optic nerve and chiasma are in your way. So the tumor has been removed this part, but not this part. This part is still there, especially that are around the carotid and optic, but this part has been removed. And this is post-op. So we diagnosed Langerhans cell histiocytosis and we wanted to start chemotherapy, but he went back to his country. Okay, this is it. If you have any questions, we are open for discussion. So Jalil, do you see these cases in children?
صوتي عالي يمكن مش دروس. أول شيء I
want to congratulate you on a very, very elegant discussion. And this is the first time after 50 years of my involvement with pediatrics that I could understand it more at ease from you. And a lot of things that changed during my work. We used to see a lot, but for the past many years, I'm not in that line. I'm very impressed with the photos you showed about the skin lesions, that we might really think that this is meningococcemia with chickenpox and send it here, that, and treat, and we will use that. The picture is very impressive. Also, we see lots of otitis media and otitis externa. I never thought about what you mentioned today. But about histiocytosis X, it used to be when I was working there, maybe once every, he's saying that he sees every 2-3 months. But in children, I haven't seen for the past maybe once every 1 year or 2 years in my practice. But again, I congratulate you for the very nice presentation. Thank you.
Have you seen cases?
Yes, I would appreciate to reinforce on the point that you mentioned that when you have auto involvement, it is bad prognostic sign. I remember a child with Dr. Mahmoud Sarhan. He died 2 months ago. His name Hamza. The first presentation was a destructive lesion in the region of the ear. Subsequently, he developed lesions in the orbit, apex, and in the pelvis and in the internal organs. And finally, he died. So I remember the ear involvement is a bad prognosis. He died, yes. I can add something. It is written that when you have craniofacial lesions, look for CNS lesions. They are usually accompanied together. Craniofacial lesion indicates CNS lesions. Once you have multiple organ lesions, every organ can be involved. About the hepatobiliary, I read about it. It is really some sort of periportal and peribiliary infiltration by granulomatous changes. So what we have in our image is definition of the portal vein and hypointensity elongate, which is the finding in cases of hepatobiliary histiocytosis.
Dr. Junaid, if you have seen cases in GI exams.
Well, before I answer this question, I think I have to say something. Every time I attend your lecture, I really enjoy it very much, and I do appreciate what you're doing. However, it kind of puts me through as if I am going through a horror movie when I see you operating on these things, and I kind of shriveled up when they see how tense you should be. I mean, going through all this, I mean, that's a real horror movie to me. But I congratulate you for your courage going through all this. As far as the from gastroenterologic point of view, I've never seen any case like that. And as you said, many of times these happen in children, so we are adult treating physicians, and I don't see them. But I want to ask a question: is whether do all these tumors carry a very high mortality rate? I mean, is there any benign presentation or any benign type of such tumors?
80% are the so-called eosinophilic granuloma that were described in the past, and these are benign. But the multisystem, this is literally Saiyd syndrome, are fatal. So 20% fatal, 80% benign. بس الدكتور كان
أنا عندي كومنت يعني أنا شفت حالات I came across a case where a child about 1 year old had multiple skin lesions. I biopsied this by skin biopsy from the scalp and from the foot, and it was eosinophilic granuloma, and he was an Iraqi patient. And also I had another case also from the skull, 2 other cases, and also they were Iraqi patients. So I confirm that it's really more common in Iraq than in other people. Probably it's related to the radiation that they receive.
Thank you. I want to ask if the difference between class 1 and class 3, you mentioned that class 3 is malignant histiocytosis. Yeah. Is this difference histopathologically or it's clinically?
Histopathologically.
Histopathologically. So for Dr. Hussam, what's the difference between malignant histiocytosis in histopathology, if you can tell us, please? And second question, for this lesion, why you choose to do transcranial approach rather than transsphenoidal?
Good question.
Thank you.
You can do it both ways. You can do it endoscopically or you do it cranially. But remember that this lesion is completely above the cella. So if you want to go there, you may damage the pituitary. You have to so-called mobilize the pituitary, which is a bad practice. Some people do it, but they end with total damage to the pituitary. So that's why I choose to do it transcranially. What was the other question?
Class 1 and 3.
That's
يمكن Dr. Ibrahim, he mentioned a case that we diagnosed, probably a case from Oman, malignant histiocytosis, and the patient died, I think, after a few months. And the histology was very much different. I mean, the histology that when you look at them, you look different, malignant cells. You wonder what are the origin of these cells. So not like histiocytosis, I show you the coffee bean nuclei and the bland looking. These cells you look like these are malignant, but I want to know what is the origin. So you know them by the special stains. But these cells, you know that they are not malignant, they are benign. The histology is number one in calling it whether benign or malignant.
And for you, Mahmoud, these are all histocytes. That's why it's called Histocyte Society classification. If they look like Langerhans or dendrites, it's called Langerhans histocytosis. But there are other non-Langerhans, like lymphocytes, like xanthogranulomas affecting the reticulohistome. So we are affecting the reticuloendothelial system. And here, we are getting the malignant one, acute monocytic leukemia, malignant histiocytosis, histocytic lymphoma. So these are the malignant forms of histocytes.
Yes, and you mentioned that for class 1, you use chemotherapy, although it's a benign lesion.
And if it is a difficult one to treat, you start with simple things like indomitacin.
That's what I want
like
to
with
ask.
the steroids, yes, of course.
You start upstairs with
Absolutely.
NSAID, steroids, then
you go
for radiation or chemotherapy.
Sure. Dr. Azman Habibi, please.
A few comments for the radiologist, yes. You remember the bevel shape appearance, which is typical for the histiocytosis, and the sclerotic button sign, which is sclerotic within the lesion. This is diagnostic. But if we go to the temporal bone, if you see bilateral temporal bone with respecting the labyrinth, this is diagnostic for histiocytosis, especially in a child. We have a case of a Syrian refugee. He was treated for 9 months for bilateral mastoiditis. And the mother, just one question, when they sent it for us to see it. When he came for renal ultrasound. And I asked her, why they want, she said to me, I told the doctor that my baby is drinking too much, urinating too much. And nobody for 9 months took this in consideration. And we suggested that for them, and that you should do MRI, because this could be eosinophilic granuloma, and it was proved to be bilateral mastoid with respect to the right, so it was diagnosed as the other thing. One case in my career, I saw that it was an ectopic posterior lobe, and the Langerhans was in the ectopic lobe, and it was not on the normal position of the posterior. Yes, it was ectopic.
Dr. Ahmed Halele, any comments? Okay. Dr. Saiyd, anybody specialty, please? Ahmed Asad, ENT, you should tell us.
I'm just asking you, is there anything to do with genetics in this case? Because I remember when I young, and we used to talk about these things, genetics, especially. Okay.
Because there is a recent interest in the genetics of this disease. Some people say it is, but it is not yet kind of.
I think there is familial, not
Exactly. It's more familial than hereditary. Yes.
Right. بالنسبة للحالة اللي بتحكي عنها اللي هو 15 months
the girl, the Iraqi girl was 12, 13.
No. You remember the first case we did on المركز العربي. He was 18 months and it was his cycle. You remember that?
دكتور ابراهيم بصفتكم حكيتوا عن المرضى most of them are from Iraq. Your patient was 2005.
Are we suspicious of what happened after
Absolutely.
2001?
Absolutely.
Or before or after?
The weapons they used in the first war and the second war is horrendous. It's a nuclear atomic bombs, basically.
And most of the other patients came after the 2001 or 2002.
Some of them old, some of them recent. So, but it is related to the American-Iraqi war. Please, for example.
This is now important. What you say.
As intracranial lesion, may we put this in the bottom of the differential diagnosis really, because it is very rare. But when there is combination of intracranial or any organ with bone findings, such we saw now in this case, or geographic appearance of the skull, so we raised this in the top of the differential diagnosis. I have seen 2 cases of little Saiyd syndrome or esophageal granuloma, but not in Jordan, in Iran, and it is common. In Iran, it is common because we a lot of cases we had, as when we saw bone lesions in the top of the differential diagnosis, it was histiocytosis.
Any comment from anybody, residents, anybody?
Yes, I was
Please.
About why it is when it is affecting the ear, it is late. Is it because we are delayed in our diagnosis? Could be, but there is no scientific reason why when it affects the ear, it is going to have a bad prognosis. We have to know the thing. Is it because we are delayed in diagnosis, or what else?
We don't know, but
what are the things?
the prognostic factors that if you have a child, it's a bad prognostic sign. If you have multiple systems, it's a bad prognostic sign. If you have ear involvement, it is bad prognostic. Why? We don't know. Who knows?
Question.
Who's the primary doctor responsible for choosing medication and follow-up for this patient?
Oncologist.
Oncologist.
Of course.
Do we have follow-up?
No, we lost him. We wanted to treat him here, but he wanted to go back. So we did
whatever the system involved, you should send him to oncologist.
Absolutely, of course. We have to stop thinking of ourselves as Superman.
Yes, yes.
We are one in a team, and we have to cooperate with each other in every patient and every aspect. And sometimes the ego takes up that we diagnose everything without real knowledge. If no questions, I thank you very much. And next week we'll have another case in the same region, but very interesting. So be there next Wednesday.
Hey, Jeffrey, how you doing? Jeffrey. Okay, we stopped taping. We stopped taping. He's still there, but ellos ignoran me. Sí, normalmente es solamente una televisión, no interacción.
Sí, sí, sí.
Ah, qué bueno, qué bonita. Es Ecuador después detrás de ti.
Sí, Ecuador.
Wow, qué bonita. Tú tienes un screen, yo tengo esto, si yo uso esto. ¿Tú usas esto o no? Green screen, ¿no? ¿Qué usa? Es muy bueno. Para background, ¿qué usa? ¿Cómo hace? Sí, qué perfecto. Wow. Tú no ponga esto, ¿eh? ¿Cómo hace esto? ¿Cómo hace?
iPad.
¿Tiene opción de ponga un background?
Sí.
Y solamente pongo una foto y ya.
Solamente con eso.
Wow, qué bueno. Porque es un gran dolor para poner esto.
Sí.
Sí, mira, si yo ponga, no tengo opción para background ahora. A veces Zoom no tiene background, necesito abrir Yeah, décame abra otra. Décame abra otra. Okay. Décame ver qué es 212. Okay. Déjame entrar de mi laptop y trato de algo background como esto.
Yo tengo uno también, aquí varios.
Como notó. Okay. No, it's 1, 2, 2, 7, 0, 2, 7, 1, 1, 6. So host, okay. Okay. Déjame salir. Quedo aquí, okay? Quedo aquí.
Estoy aprendiendo a manejar esto. El hospital.